All right, so a very good evening, everyone. Yes, so am I audible and visible to all of you? Right, yes, am I audible and visible to all of you? Okay, now in this particular session, let me discuss the hepatobiliary emergencies. So I am myself Dr. Rajesh Gubba. I am the general medicine educator. So now let us start this particular session with a positive note. Okay, so what is that particular positive note is? You need to know what exactly is the theory of life, because the NEET PG exam is coming nearby. So there are students who are appearing for the exam for the first time, and there are certain students appearing for the second and as well as third time as well, or like multiple times as well. So what you have to remember, the theory of life is that whenever the flood comes, the fishes will come to the shore, and the fishes will eat the ants. But when the same water dries, the ants, they eat the fishes. So what is that you have to understand from this is that life gives chance to everyone. What is that you need to do? Just you have to wait for our turn. Okay, you need to just wait for our turn. Okay, so अपना time के लिए like थोड़ा wait करना पड़ेगा. So that is a very very important theory of life. So you should not get disappointed either when you are getting like low marks in your grand test, or you should not get disappointed when you are appearing for the exam like second time or third time or fourth time. Right? We need to just wait for our time, and until then our efforts should be continuous. That is a very very important theory of life. And another aspect is, see, you have to believe in yourself. Everything is possible. When you believe in yourself, everything is possible. It is when you don't believe in yourself, then you will not be able to achieve anything. So keep one important thing in the mind: there is nothing impossible if you keep your efforts consistently. That is very very important aspect of the life. So believe in yourself that you will definitely clear this particular exam, and you will definitely do the exam well, and you will definitely get the clinical branch or the branch of your own choice. Okay, so that positive attitude is very very important. See, actually, if you take your brain or you take your mind, your brain or mind is an immense source of energy, right? It is an immense source of energy. You just need to channel it into a positive direction. If you don't channel your brain or mind into a positive direction, then it becomes little difficult for us to achieve the success like what we actually want. So with this positive note, let us start with the today's session of the hepatobiliary emergencies. Okay, right. So now, yes, what are all the hepatobiliary emergencies that I'll be discussing now? So, I'll be discussing the hepatic encephalopathy, the portal hypertension, spontaneous bacterial peritonitis, tense ascites, where the individual can develop abdominal compartment syndrome, then hepatorenal syndrome, and then hepatopulmonary syndrome. And I will be also discussing the autoimmune hepatitis. So, these are the hepatobiliary emergencies. Yes, Bansal, yes, the emergencies, emergency medicine sessions are also very, very important for your NEET PG exam as well. Okay. So having said this, let me just show you so I will try to take up the entire session in the form of giving you the clinical scenarios. Then accordingly, we'll try to solve that particular clinical scenario. So the first clinical scenario is a 73-year-old man with history of alcoholism and hepatitis C, presents with lethargy and hypersomnia. That means excessive sleep. He has been sleeping all day and not taking any of his medication. On examination, the patient has the ascites, palmar erythema, edema, and spider telangiectasia. Right? He also has the flapping motions of his hand when dorsiflexed. Laboratory tests reveal normal ammonia levels. Mark my point here. Laboratory test reveals normal ammonia levels. Now, what do you think is the diagnosis in this clinical scenario? Yes. What do you think is the clinical scenario in this patient? Any one of you, please. So, if you take the clinical scenario in this patient, even though the serum ammonia levels are normal, still we consider this particular patient is having the hepatic encephalopathy. As such, in almost 85 to 90 percentage of individuals with hepatic encephalopathy, the ammonia levels, they are elevated. It is the ammonia which is the most important toxic substance which is elevated in patients with hepatic encephalopathy, and that will cross the blood-brain barrier, will accumulate in the brain, causing encephalopathy. But apart from ammonia, there are many other toxic substances which can contribute to the development of hepatic encephalopathy. So that means in 5 to 10 percentage of patients, apart from ammonia, you need to know what are the other toxic substances which can contribute to hepatic encephalopathy. So the other toxic substances, they include gamma amino butyric acid. Then the next important substance is mercaptans. Next, short chain fatty acids. Next, octopamine. So these are the other toxic, and one more toxic substance, that is phenol. Right? So as of now, every one of you are under the impression that ammonia should definitely be elevated in patients with hepatic encephalopathy, right? It need not be always. In 5 to 10 percentage of patients, ammonia levels may be normal, but other toxic substances will be elevated that will cross the blood-brain barrier and will accumulate in the brain, causing the manifestations of hepatic encephalopathy, right? So here, the most likely diagnosis in this patient is the hepatic encephalopathy. Now, let me discuss in detail about the hepatic encephalopathy. So, I have mentioned all these toxic substances. Ammonia, the most important. Then gamma aminobutyric acid, mercaptans, which are derived from methionine, short chain fatty acids, octopamine, phenol. These are all the toxic substances. Now, you should know what is the earliest clinical manifestation. The earliest clinical manifestation, these patients, they will have inversion of sleep rhythm, right? These patients, they will have inversion of the sleep rhythm. Now, what do you mean by the word the inversion of sleep rhythm? That means they will have decreased sleep or disturbed sleep all through the night, but all through the daytime they will have excessive sleepiness. That is what is being mentioned in our clinical scenario also. What is that? There is hypersomnia, sleeping all the day. That is the earliest clinical manifestation in patients with the hepatic encephalopathy. Then followed by that, you need to know the earliest examination findings. See, please remember, earliest examination findings is not flapping tremors. Earliest examination finding is not flapping tremors in hepatic encephalopathy. So the earliest examination finding is constructional apraxia, right? Constructional apraxia. That will be the earliest examination findings. So please remember, this is a very, very important point. Then followed by that, you will have the other manifestation, that is in the form of flapping tremors. Okay, but the earliest examination finding will be constructional apraxia. Now, what exactly you mean by this word constructional apraxia? See, constructional apraxia is that now you draw a simple image, right? You draw a simple image. Now you ask the patient to draw the same image. Even though the motor activity is normal, he will not be able to do that. He will not be able to draw that particular simple image what you have drawn. And that is what is called as the constructional apraxia. That is the earliest examination finding. Okay, then followed by that, you have this flapping tremors. But at the same time, you should know the differential diagnosis of the flapping tremors. The other conditions where you can have the flapping tremors is, you can have this in patients with carbon dioxide narcosis, right? And you will also have this in patients with the uremic encephalopathy, right? Uremic encephalopathy. So these are the differential diagnosis for the development of flapping tremors. Okay. Yes, Parth Agarwal, when will you take acute kidney injury and chronic kidney disease? Yes, Parth Agarwal, I have already discussed acute kidney injury and chronic kidney injury when I am discussing nephrology emergencies. So you just go back to the nephrology emergencies on DBMCI YouTube live channel. So you will have this acute kidney injury and as well as chronic kidney injury on the in the nephrology emergencies. Okay, right. Next, then what do you think is the most relevant investigation? Most relevant investigation is the ammonia levels. The ammonia levels are being elevated in these individuals. That is the most relevant investigation, right? Then apart from that, you need to know the EEG, that is electroencephalograph. Electroencephalograph is another very important investigation in these patients. Now in electroencephalograph, what is that you will observe? In electroencephalograph you will observe the presence of the triphasic waves. This is a very important point. You will observe the presence of the triphasic wave, and when you get this triphasic wave, you will get this particular triphasic wave when the individual is in stage 4 of hepatic encephalopathy, and stage 4 of hepatic encephalopathy is nothing but coma. So let me tell you, there are totally 6 stages in the hepatic encephalopathy. Stage 1, the individual is alert. Stage 2, the individual is drowsy. Stage 3, the individual is having stupor. Stage 4, the individual will be in a state of coma. The stage 5, the individual will be in a state of deep coma, and stage 6, where there will be brain death. The EEG will be completely flat. Okay, so EEG is another important investigation. Next, then what is the best initial therapy? See, the best initial therapy in these patients is you need to supplement lactulose. Now, what is the importance of the lactulose? See, whenever you give lactulose, what it will do, this ammonia which is there in excessive quantity, this ammonia is converted into ammonium, and this particular ammonium is excreted out. Right, ammonium is excreted out through the feces, but ammonia cannot be excreted. So lactulose is considered as the best initial therapy or the drug of choice. Then next to the lactulose, what is the next best antibiotic that you have to give, or the next best therapy? That is, you need to give rifaximin. Now, what is the purpose of giving rifaximin? You need to give 550 milligrams twice daily, and this particular rifaximin, what it will do is it will reduce the recurrence of hepatic encephalopathy. Now, in what way the rifaximin will reduce the recurrence of hepatic encephalopathy? Right, that is, like rifaximin, it is bacteriostatic. Rifaximin is what? 1 minute. One second. So rifaximin, yeah, it is bacteriostatic. That means what it will do, it will kill the intestinal bacteria. It will kill the intestinal bacteria. So once it kills the intestinal bacteria, like what will happen? The production of the ammonia reduces. Okay, that is the purpose of giving rifaximin. And what is the another important treatment options? The other important treatment options are supplementing or giving enema. Now, what is the purpose of giving enema? See, if there is constipation, constipation will precipitate your hepatic encephalopathy. By giving enema, the constipation can be reduced, thereby the precipitation, one of the precipitating factor can be avoided. Next is, these patients you have to give fresh frozen plasma. Vitamin K is not recommended. Fresh frozen plasma you have to give. And these patients, they go into a state of hypoglycemia because of hepatic failure. So you should give 10% dextrose or 10% glucose you have to give, right? And another very important substance is ornithine transcarbamylase. Right, you should give ornithine transcarbamylase. What is the purpose of giving this ornithine transcarbamylase? That will help in clearing the ammonia from the body. So that is about like the treatment in patients with a hepatic encephalopathy. Now I'll just wind up this hepatic encephalopathy just by telling you what are the precipitating factors. Right, please answer this question. Which of the following is not a precipitating factor for hepatic encephalopathy in patients with chronic liver disease? Hypokalemia, hyponatremia, hypoxia, metabolic acidosis. Which of the following is not the precipitating factor? Any one of you? Right. So please remember, it is not your metabolic acidosis. It is your metabolic alkalosis which is a precipitating factor. So please remember your hypokalemia, hyponatremia, hypoxia, metabolic alkalosis. Not only that, gastrointestinal bleeding, then constipation, then azotemia. So, and even your hypovolemia. All these are the precipitating factor for the development of hepatic encephalopathy. Okay, so this finishes one of the very important emergency, that is hepatic encephalopathy. So I'll quickly recap the hepatic encephalopathy. So in hepatic encephalopathy, the important toxin which is elevated is ammonia. And what are the other toxins which are elevated? Gamma aminobutyric acid, mercaptans, short chain fatty acid, octopamine, and as well as the phenol. Then the earliest clinical manifestation is the inversion of the sleep rhythm. Followed by that, they will have altered sensorium and all. And the earliest examination finding in these individuals will be constructional hypoxia, and then followed by that flapping tremors. And differential diagnosis for the flapping tremors will be carbon dioxide narcosis and as well as the uremic encephalopathy, right? And next you need to know the most relevant investigation. Most relevant investigation is increased ammonia levels. Then followed by that you need to know the EEG. EEG will show you the presence of triphasic wave pattern, and that too in stage 4 of your hepatic encephalopathy, right? Then you need to know the treatment. See, the earliest initial therapy that you need to give is lactulose, then followed by that the other therapies. What is that other therapies? Rifaximin, enema, fresh frozen plasma, 10% glucose, then ornithine transcarbamylase. And what are the precipitating factors? Gastrointestinal bleeding, excessive dietary protein, azotemia, constipation, hypokalemia, alkalosis, hypoxemia, hyponatremia, hypovolemia. These are all the precipitating factors for the development of your hepatic encephalopathy. Right, so that is about the story related to hepatic encephalopathy. Now, after having discussed about the hepatic encephalopathy, next emergency we'll try to discuss. Right, so you see this question, clinical scenario. So we have a 47-year-old man with chronic alcoholism, presents with abdominal pain and fever. He has had multiple admissions for variceal bleeds and ascites requiring large volume paracentesis. The pain is diffuse and has been getting worse since yesterday. He also has fever, chills, rigors. On examination, he has diffuse tenderness over the abdomen with shifting dullness and fluid wave. What is the most common organism responsible for this? Yes, please answer this question. Yes, any one of you? Right. So the correct answer in this question is, so what is the diagnosis here? Basically, the diagnosis here is the spontaneous bacterial peritonitis. Because what is the point to tell you that the individual had spontaneous bacterial peritonitis? First and foremost, very important is the individual had multiple times large volume paracentesis, multiple times large volume paracentesis, and the individual is having pain which is diffuse and has been getting worse since yesterday. The patient is also having fever, chills, and rigors. These are all the clinical presentations in patients with a spontaneous bacterial peritonitis. And remember, the most common organism causing spontaneous bacterial peritonitis is the Escherichia coli, right? And next to the Escherichia coli, the another important gram-negative organism will be the Klebsiella. But if the question is asked, what is the gram-positive organism that will be causing spontaneous bacterial peritonitis, that will be your streptococcus. And your spontaneous bacterial peritonitis is a very, very important emergency, and if you don't treat the patient, the individual will end up in sepsis. So let me just quickly recap in 2 minutes about the spontaneous bacterial peritonitis. So the most common organism is what? That is the Escherichia coli, then followed by the Klebsiella, and the gram-positive organism will be the streptococci, right? And what will be the clinical features? The individual will have diffuse pain over the abdomen, and there will be also abdominal tenderness. Then the diagnostic test is very, very important. Whenever you take the ascitic fluid and when you do analysis, you take WBC. How many WBC should be there? More than or equal to 500 cells per microliter, more than or equal to 500 cells per microliter. Or if you take the polymorphonuclear leukocytes, the polymorphonuclear leukocytes should be more than or equal to 250 cells per microliter. So that is what is the accurate diagnostic test for your spontaneous bacterial peritonitis. Then what is the drug of choice? The drug of choice will be third generation cephalosporin, that is cefotaxime. right? That will be cefotaxime. That will be the drug of choice. Then what will be the prophylactic antibiotic in order to prevent the recurrence? In order to prevent the recurrence, the prophylactic antibiotic that you can give is ciprofloxacin or norfloxacin should be given. Now, the very important point is, for suppose a patient with spontaneous bacterial peritonitis is having acute on chronic liver failure. The patient is having acute on chronic liver failure. Then what is the antibiotic that is being recommended? The antibiotic that is recommended here is meropenem and daptomycin is being recommended. Right, meropenem and as well as the daptomycin is being recommended, and along with this the patient has to also be supplemented with the intravenous albumin. And how much of intravenous albumin you have to give? 1.5 grams per kg at the time of diagnosis you have to give, and after that on day 3 you have to give 1 gram per kg of intravenous albumin. So that is about your spontaneous bacterial peritonitis. So you should know most common organism, presenting symptom. This is very important in this. That is, accurate diagnostic test is very important in this. Then followed by that antibiotic drug of choice, and what will be the drug for prophylaxis. Then in patients with liver failure with spontaneous bacterial peritonitis, what is the antibiotic that you need to give? Now, very frequently asked questions in the entrance exams is about the scoring systems. This is very important. They are very frequently asked. What are the components of MELD score? What is the indication of MELD score? What is discriminant function score? What is the requirement of calculating the discriminant function score? What is the child pug scoring system, and what will be the score to determine the severity? These three are very important scoring systems. Now you take this MELD score. What is this MELD score? MELD score stands for Model for End Stage Liver Disease. Right, model for the end stage liver disease. That is what is called MELD score. Now, first important thing that you need to know is what are the components of your MELD score. The components of MELD score will be the serum bilirubin, then the serum creatinine, then the INR. Okay, or the prothrombin time. So these are the three important components of the MELD score. See, formula is not required. How do you calculate this MELD score is not required. At least you need to know the parameters of your MELD score, and accordingly, if you know the scoring system, for example, if the MELD score is like more than or equal to 40, the chance of mortality is 71.3%, and if the MELD score is like 30 to 39, the chance of mortality is 52.6%, and if the MELD score is less than 9, the chance of mortality is 1.9%. Okay, so three parameters you need to know: bilirubin, INR, serum creatinine. Now, what is its importance? Now, for suppose if you calculate the MELD score, and if the value of the MELD score is more than 14, then he is a candidate who has to undergo orthoptic liver transplantation. The patient has to undergo orthoptic liver transplantation. That is the importance of your MELD score. Then another important scoring system for assessment of the liver severity is the discriminant function score. Now, in discriminant function score, you have only two parameters. What are those two parameters? एक होगा आपका bilirubin and दूसरा होगा आपका the international normalized ratio, right? And formula is not required. Then what is the importance of it? In which conditions we calculate this discriminant function score? We calculate the discriminant function score in patients with alcoholic hepatitis. And why do we calculate? We calculate this discriminant function score whether to give steroids or not. Right, whether to give steroids or not. In order to prescribe steroids or pentoxifylline in patients with alcoholic hepatitis, we calculate this discriminant function score. Now, if the discriminant function score is more than 32, if the discriminant function score is more than 32, it is an indication for that you need to give steroids or pentoxifylline. Okay, so this is very important. Discriminant function score, alcoholic hepatitis. Whereas the child pug score is for what? The child pug score is for cirrhosis of liver. Now you need to know what are the components of child pug score. So just remember bilirubin, albumin, ascites, asterixis, raised INR. These are the 5 components. Okay, so just remember these are the 5 components. Okay, by okay, that is bilirubin, albumin, ascites, asterixis, raised INR. Now, what did we discuss in the MELD score? If the MELD score is like more than 14, we need to do orthoptic liver transplantation. Whereas if the child score is more than or equal to 7, that is an indication that you need to do liver transplantation. So please remember these three scoring systems. These are the very, very important areas where the questions will be asked in your NEET PG exam. Right? Child score, MELD score, DF score. Okay? Done. So we are done with the second important hepatobiliary emergency, that is spontaneous bacterial peritonitis. And if you don't treat the patient, the individual will land up in sepsis, septic shock, and finally death of the individual. Okay, right. Next. Now, let us discuss one more important emergency in the hepatobiliary system. That is a 49-year-old alcoholic man presents with hematemesis that began 2 hours ago. He was intubated for airway protection. His past medical history is significant for hepatitis C that has not been treated. He consumes 1 bottle of whiskey a day. He is tachycardic to 140 beats per minute. Blood pressure 99/68. Dried blood is seen in the oral cavity. Palmar erythema is present. Telangiectasia is also seen on the thorax. AST and ALT are 156. Prothrombin time is elevated and hemoglobin is 6. What is the... See, these are the type of questions which will give us lot of trouble. Next best step in the management. IV fluids and blood products, octreotide, endoscopic band ligation, tips, transjugular intrahepatic portosystemic shunt. Yes, please answer this question. Yes. Right. So if you take the answer in this question here, it is IV fluids and as well as the blood products. This will be the first initial thing that you need to do. Why? Because you need to stabilize this patient. You need to stabilize this patient because there is hypotension of 99/68 and even your prothrombin time is elevated. So there is excessive bleeding tendency and hemoglobin is also very less. So IV fluids and blood products are the first important thing. Once you stabilize your hemodynamics, then you try to correct where exactly is the abnormality. In acute event, what we need to do is, in acute event, try to correct the hemodynamics first. Once you have corrected that hemodynamics, then you try to treat what exactly is the reason for that abnormal hemodynamics. Okay, right. Now, coming to the diagnosis. What exactly is the diagnosis in this patient? The diagnosis in this patient is the portal hypertension causing the esophageal varices which are being ruptured. Right, which are being ruptured. And at this point you should know like normal portal venous pressure also. How much is the normal portal venous pressure? That is 5 to 10 millimeters of mercury. And when you call portal hypertension? When the portal venous pressure is more than 10 millimeters of mercury, then we use the word portal hypertension. Right. Next, what is the next best step? Like just now I have discussed, that is IV fluids and as well as the blood products. Right, IV fluids and as well as the blood products. That will be the next best step in this individual, right? And what exactly are these esophageal varices? These esophageal varices are nothing but dilated submucosal veins in the lower third of the esophagus. Right, dilated submucosal veins in the lower third of the esophagus that have become engorged due to portal hypertension. Okay, and in these patients with portal hypertension, they will not only have esophageal varices. What are the other important features of portal hypertension apart from esophageal varices? They can also have caput medusa surrounding the umbilicus. They can also have the rectal hemorrhoids. And if these rectal hemorrhoids rupture, the individual can also have the bleeding per rectum. Then another important reliable sign is splenomegaly. Another important reliable sign in case of portal hypertension will be splenomegaly. Then what will be the investigation of choice in patients with the portal hypertension? The investigation of choice will be the Doppler ultrasonography. So Doppler ultrasonography will be the investigation of choice. Okay. Then you should know, right, then you should know the best initial therapy. The best initial therapy is that you need to give octreotide, which is nothing but somatostatin analog. And if there is availability of terlipressin, you can also give alternative drug will be the terlipressin. So what these drugs basically do, they will cause vasodilatation of the splanchnic vessels. By causing vasodilatation of the splanchnic vessels, they reduce the portal pressure, and that will be the best initial medical management, right? Then Next is most appropriate therapy. So once you have stabilized hemodynamically, right, then the most appropriate therapy is that you need to do endoscopy, right? You need to do endoscopy, then you need to do esophageal variceal ligation or endoscopic band ligation. Esophageal variceal ligation or endoscopic band ligation. Okay, so that is about like the most appropriate therapy. Okay, then how to control the bleeding? See, once you have done esophageal variceal ligation, the bleeding will stop. But if the bleeding is not controlled in spite of esophageal variceal ligation, then what you can place is you can place Sengstaken Blackmore tube. Right, Sengstaken Blackmore tube. This Sengstaken Blackmore tube, right, the Sengstaken Blackmore tube, that will be acting as a bridge for the tips. That will be acting as a bridge to the tips, that is transjugular intrahepatic portosystemic shunt. Then what is the discharge advice? See, once you have done esophageal variceal ligation and once further bleeding has been stopped, you have to control your portal venous pressure. Your portal venous pressure should be less than 10 millimeters of mercury. So for that we need to give beta blocker, that is propranolol, or you need to give nadolol, right? Propranolol, or you need to give nadolol. So this is how you will discharge the patient. Okay, so this is about your portal hypertension. So to quickly recap, the portal hypertension, normal portal venous pressure is 5 to 10 millimeters of mercury. When the portal venous pressure is more than 10, we call it as portal hypertension. And the implications of portal hypertension is esophageal varices causing rupture of esophageal varices, due to which there will be hematemesis. There can be caput medusae. There can be also rectal hemorrhoids. And please remember, the initial step is, the best initial step is the IV fluid and as well as blood products. And medical management, like what is that you need to give is octreotide or terlipressin. And most appropriate therapy will be endoscopy. Followed that, you need to do esophageal variceal ligation. And if the bleeding is still continuing in spite of EVL, you need to place Sengstaken Blackmore tube that will act as a bridge to your tips. And on the discharge, once the bleeding is stopped from the esophageal varices, you need to give beta blockers, that is propranolol or nadolol, that will reduce the portal venous pressure to less than 10 millimeters of mercury, right? So that is about. And now what is the advantage of doing this particular tips? What is the advantage of doing this particular tips, that is transjugular intrahepatic portosystemic shunt? So like what are you doing now in case of transjugular intrahepatic portosystemic shunt? You are connecting, right, you are connecting the portal vein directly to the hepatic vein. That means whatever the portal venous pressure is there, that will be transmitted to the hepatic vein, and then the blood will enter into the inferior vena cava. Okay, actually previously what used to have, this portal vein will break into portal sinusoids, and these portal sinusoids, all of them will unite to form the hepatic vein. But whenever there is portal hypertension irresistible, then in the tips what we do is portal vein is directly connected to the hepatic vein by a shunt, where the portal venous pressure will be transmitted to the hepatic vein, and from there the hepatic vein will transmit the pressure to the inferior vena cava, and that will be the ultimate therapy for these patients, that is TIPS, transjugular intrahepatic portosystemic shunt, right? So once we are done with this particular portal hypertension causing the rupture of esophageal varices, that is another important emergency. So what all hepatobiliary emergencies we have discussed? Hepatic encephalopathy, spontaneous bacterial peritonitis, ruptured esophageal varices, how to manage the next. Now the fourth important is abdominal compartment syndrome. Okay, what should be the abdominal pressure in abdominal compartment syndrome? So this is one of a PYQ, previous year asked question. Okay, now for this you need to know, how much is the normal intra-abdominal pressure. So if you take the normal intra-abdominal pressure, yes, anyone want to make an attempt of this question? Right, now the normal intra-abdominal pressure is less than 10 millimeters of mercury. And when will the individual develop abdominal compartment syndrome is when the intra-abdominal pressure if it is more than 25 millimeters of mercury, then the patient will develop the abdominal compartment syndrome. So in case of abdominal compartment syndrome, what will happen is, because of excessive increase in the abdominal pressure, there will be kinking of the blood vessels, right? There will be kinking of the blood vessels supplying to the visceral organs, right? Supplying to the visceral organs. So once there is kinking of the blood vessels supplying to the visceral organs, then there will be development of the wet gangrene, right? There will be development of wet gangrene. So this is about your abdominal compartment syndrome. Now let me just discuss, like, when will this individual develop abdominal compartment syndrome? That is, whenever there is massive ascites, then there will be development of this abdominal compartment syndrome. Okay, so in patients with like cirrhosis of liver, that particular cirrhosis could be due to alcohol, or it could be due to drugs, or it could be due to viral hepatitis. But in order to call it as ascites, what should be the quantity of the fluid in the peritoneal cavity? In order to call it as ascites, like, what should be the quantity of the fluid? Please remember, if the quantity of the fluid, if it is more than 25 ml in the peritoneal cavity, or if the peritoneal fluid is more than 25 ml in the peritoneal cavity, we call it as ascites. Whereas if you take ultrasound can detect the ascitic fluid up to 100 ml, right? Can detect the fluid up to 100 ml. Then when will you get the Poodle sign being positive? I'll show you what is that Poodle sign. The Poodle sign will be positive when the quantity of the fluid in the abdominal cavity is around 100 to 120 ml. Next, when will you have the shifting dullness being positive? The fluid should be nearly around 500 ml. That is the point when you will have the shifting dullness being positive. When will you have the fluid thrill? That will be positive. That is around 1 to 1.5 liters. Right, when the quantity of the fluid in the abdominal compartment is around 1 to 1.5 liters, then the fluid thrill will be positive. Now, when do we use a terminology called intra-abdominal hypertension? So when the intra-abdominal pressure, if it is increasing to more than 12 millimeters of mercury, we use the word intra-abdominal hypertension. And when will you call it as compartment syndrome? In case of abdominal compartment syndrome, the intra-abdominal pressure will be more than 25 millimeters of mercury, and in that very high pressure, there will be kinking of the blood vessels resulting in wet gangrene. So what is that we are very much worried about in case of abdominal compartment syndrome is there will be development of wet gangrene. There will be development of wet gangrene. Next, what do you understand by this word? The tense ascites. See, tense ascites, it is secondary to massive ascites only. It is secondary to massive ascites. But then what is the difference between the tense ascites and as well as massive ascites? In case of massive ascites, you have the presence of the fluid thrill. The fluid thrill is being present in case of the massive ascites. But whereas in case of tense ascites, please remember the fluid thrill is absent. Right? The fluid thrill is absent in case of tense ascites. Okay, why the fluid thrill is absent? Because the fluid is under high pressure, which is like tightly packed in the peritoneal cavity. Even though you apply or even though you do a fluid thrill, the fluid thrill will be absent. Okay, right. Now one quick question I wanted to images what I wanted to show you is about the Poodle sign. So this is how the Poodle sign is being elicited. So you need to make the individual to make him lie down in the knee elbow position, and the fluid will be accumulated in exactly at the center of the abdomen. So when you start percussion, the flanks will be tympanic note. The flanks you'll have tympanic note, but the center of the abdomen you will have dull note. And when will you have this Poodle sign being positive? When the quantity of the fluid is around 100 to 120 ml. That is the point when the Poodle sign will be positive. Then we were discussing about the shifting dullness. This is how we will do shifting dullness. Shifting dullness, when will you have it positive? When the quantity of the fluid is nearly around 500 ml. Then followed by that, we were discussing about the fluid thrill. And the fluid thrill will be positive. Around 1 to 1.5 liters are there. And that can be seen in case of massive ascites. But what is the difference between massive ascites and as well as tense ascites? In case of tense ascites, the fluid thrill will be absent. The fluid thrill will be absent. Now, what is the treatment of choice in patients with the tense ascites? What is the treatment of choice in patients with the tense ascites? In case of tense ascites, you need to do immediate, right? You need to do immediate abdominal paracentesis. Right, you need to do immediate abdominal paracentesis, otherwise the patient will end up in abdominal compartment syndrome resulting in wet gangrene. So this is about your abdominal compartment syndrome. So abdominal compartment syndrome can occur secondary to your tense ascites, and all these are very important multiple choice questions in the topic of ascites. Okay, right. Next, the other important hepatobiliary emergency is the hepatorenal syndrome. Right, hepatorenal syndrome, that is secondary to cirrhosis of liver. There can be abnormal renal manifestations. Now, in case of which of the following drugs should be avoided in case of the hepatorenal syndrome? Octreotide, terlipressin, diuretics, norepinephrine. Which of the following drugs should be avoided in hepatorenal syndrome? Okay, now let me discuss about the hepatorenal syndrome. So the drugs that has to be avoided is the diuretics. Now let me discuss about that, why diuretics should be avoided. Now let me complete the entire discussion of hepatorenal syndrome in one single slide. Now what percentage of patients with cirrhosis of liver they develop hepatorenal syndrome? It is only 10%. Now what is the definition of hepatorenal syndrome? Hepatorenal syndrome, it is the development of renal failure. It is the development of renal failure with normal tubular function. Right, with normal renal tubular function in a patient with chronic liver disease. That is what is your hepatorenal syndrome. So hepatorenal syndrome is a renal failure with normal tubular function in patients with the chronic liver disease. And these patients, if you take the kidneys, you know how the kidneys will be in these individuals? The kidneys, they will be histologically absolutely normal. The kidneys, they will be histologically absolutely normal. Okay, right. And even such kidneys have been successfully transplanted and functioning well. That is what you will have in case of the hepatorenal syndrome. Now, what is the criteria to call it as hepatorenal syndrome? So the criteria to call it as hepatorenal syndrome is that there should be azotemia. What do you understand by the word azotemia? The azotemia means there should be increase in your serum creatinine. And how much should be that? There should be increase in serum creatinine more than 0.3 milligrams per deciliter within 48 hours. That is the criteria to call it as hepatorenal syndrome. Or there should be increase in 50% of the serum creatinine from the baseline value within 7 days. Okay, either there should be increase in serum creatinine more than 0.3 milligram per deciliter within 48 hours, or increase in serum creatinine by more than 50% from the baseline value within the previous 7 days. That is the criteria. Then what are the precipitating factors for the development of precipitating factors for the development of the hepatorenal syndrome? Precipitating factors include the gastrointestinal bleeding. The precipitating factors include the development of sepsis. Precipitating factors include supplementation of the diuretic therapy. So diuretic therapy is one of the precipitating factors for the development of hepatorenal syndrome. So diuretic therapy should be avoided in these patients with HRS. And the other important thing is aggressive paracentesis. When you do aggressive paracentesis, that is also the precipitating factor. Now, if you take the pathogenesis, so if you see the pathogenesis in these individuals, splanchnic vasodilatation. Right, splanchnic vasodilatation. Splanchnic vasodilatation causes reduction in effective arterial blood volume and thereby decreasing the mean arterial pressure. So splanchnic vasodilatation, which is occurring in patients with cirrhosis of liver, is the pathogenesis that will happen in these individuals. Then you have two types of hepatorenal syndrome. And what will be the presentation? What will be the kidney manifestation? They will have oliguria, decreased urine output, and there will be also hyponatremia, and that is nothing but your dilutional hyponatremia. And your hepatorenal syndrome is of two types, that is hepatorenal syndrome type 1 and type 2. So your hepatorenal syndrome type 1 is acute kidney injury, whereas hepatorenal syndrome type 2 is the chronic kidney disease. So this acute kidney injury hepatorenal syndrome, previously it is called hepatorenal syndrome type 1. Now what exactly happens in this hepatorenal syndrome type 1 is that in these individuals, right? In these individuals, there will be doubling of the serum creatinine levels, right? There will be doubling of the serum creatinine levels to greater than 2.5 milligrams per deciliter, okay? Or there will be decrease in the creatinine clearance to less than 20 ml per minute. That is what in HRS1. Whereas you take HRS2, right? That is chronic kidney disease hepatorenal syndrome. That is your HRS2. That means here the development of renal impairment, that will be slow. Okay, so renal manifestations will be slow, progressive, and as well as chronic. So which is more dangerous? Your HRS1 is more dangerous. Okay, so in the treatment, if the patient is on diuretics, the individual has to completely stop the diuretics, right? And what will be the drugs that you need to supplement? The drugs that you need to supplement in these individuals will be midodrine plus octreotide. Midodrine plus octreotide, or you can give intravenous norepinephrine that will cause splanchnic vasoconstriction, or you need to give intravenous terlipressin, even that will also cause the splanchnic vasoconstriction, because the pathogenesis is splanchnic vasodilatation. So when you give this intravenous norepinephrine or intravenous terlipressin, that will cause splanchnic vasoconstriction, and thereby it will reduce the development of your, or the progression of your hepatorenal syndrome. Okay, right. Then what is the ultimate treatment in these patients with the hepatorenal syndrome? Ultimate treatment is that you can do TIPS, okay, that is transjugular intrahepatic portosystemic shunt, and but many patients may even worsen even after doing TIPS. The ultimate treatment could be the liver transplantation. Liver transplantation is the ultimate treatment of choice in patients with the hepatorenal syndrome. So this is about in toto of hepatorenal syndrome. So please remember, hepatorenal syndrome is a very, very important hepatobiliary emergency where the patient is having oliguria causing pulmonary edema, causing death of the individual. And in what percentage of patients with cirrhosis they develop? 10% of patients with advanced cirrhosis they develop hepatorenal syndrome, right? And in these individuals, there will be development of renal failure with normal tubular function in a patient with chronic liver disease, and these kidneys, they are histologically they are normal, and pathogenesis will be splanchnic vasodilatation. Precipitating factors will be gastrointestinal bleeding, diarrhea, diuretic therapy, and aggressive paracentesis. The criteria is that there should be azotemia. That means there should be increase in serum creatinine level more than 0.3 milligram per deciliter within 48 hours, or increase in the serum creatinine by 50% from the baseline value within 7 days. Okay, and next important is presentation will be in the form of oliguria, and whenever you take the serum sodium levels, there will be hyponatremia. HRS type 1 will be acute kidney injury with hepatorenal syndrome. HRS type 2, it is chronic kidney disease. The drugs that you need to give is midodrine plus octreotide, or intravenous norepinephrine, or intravenous terlipressin, and the ultimate treatment will be liver transplantation. Okay, so this is about one of the very, very important, right? This is about very, very important treatment in patients with the hepatorenal syndrome, and as well as the one of the hepatobiliary emergency, right? Then once we are done with this, pentoxifylline. See, pentoxifylline we give in case of alcoholic hepatitis. Yes, Manas Datta, pentoxifylline we give in case of alcoholic hepatitis, and that too when your discriminant function score is more than 32. When the discriminant function score is more than 32, either you give steroids or we give this particular pentoxifylline in case of acute alcoholic hepatitis. Okay, right. And one more important hepatobiliary emergency will be, yes, hepatopulmonary syndrome. Hepatopulmonary syndrome. You know, these patients with the cirrhosis of liver, they may present to the emergency department with sudden onset dyspnea. Why could be that? What could be the reason for that? That is one of the reason is the hepatopulmonary syndrome, right? And in these patients with the hepatopulmonary syndrome, there will be platypnea, right? Why there is platypnea in hepatopulmonary syndrome? Options are due to vascular dilatations at the base of the lung, due to vascular dilatations at the apex of the lung, due to pulmonary restriction caused by massive ascites, due to decreased venous return. Yeah, Motababi. I will send you the PDF. I'll send you the PDF on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, or I will just send this particular PDF on DBMCI Premier Group in the Facebook. Okay, right. Now, so the answer in this question is that is due to vascular dilatation at the base of the lung. Right now, why there is vascular dilatation at the base of the lung in patients with the hepatopulmonary syndrome? What is platypnea? First of all, platypnea is that these patients, they will have dyspnea in upright position. Okay, and whenever the individual attains the supine position, the dyspnea decreases. Okay, so that is what is your platypnea. Right now, why does it occur and all, let me try to explain to you. So in patients with cirrhosis of liver, there is release of the vasodilator material. What is that? That is nitric oxide, and this particular nitric oxide will preferably act only on the vessels which are present at the base of the lung, causing vascular dilatation. So there will be increased perfusion to this particular lung, but there will be decreased perfusion in the vessels which are there above. So these patients in the sitting posture, they can have the problem of dyspnea, but the same individual, whenever he attains the supine position, what happens is, in the supine position there will be improvement of the oxygenation in supine position. Why is that? Because the blood is redistributed from base of the lung to the apices in the supine position, whereas there will be intrapulmonary vascular dilatation which are predominant at the base of the lung. Standing will worsen the hypoxemia, or standing will worsen the dyspnea. That is the problem in patients with the hepatopulmonary syndrome. And what is the terminology we use? Platypnea, orthodeoxia. What is orthodeoxia? Orthodeoxia is nothing but the development of hypoxemia in sitting posture. Development of hypoxemia in sitting posture. That is what is your platypnea orthodeoxia syndrome. Now, let me explain to you in detail about this particular hepatopulmonary syndrome. What will be the clinical presentation? The clinical presentation will be in the form of shortness of breath. Shortness of breath in sitting posture. And in these individuals with hepatopulmonary syndrome, there is a triad. What is a triad? There should be the chronic liver disease, right? There should be increased A gradient. What is that increased A gradient? That is alveolar arteriolar gradient. There will be increased A gradient. And the third important part of the triad is there should be intrapulmonary vascular dilatations at the base of the lung. Right? Intrapulmonary vascular dilatation at the base of the lung. Okay, so this is about your hepatopulmonary syndrome triad. Now, what is the most sensitive screening test in these patients with the hepatopulmonary syndrome? That is contrast enhanced echocardiography. Contrast enhanced echocardiography is a sensitive screening test for detecting the pulmonary vascular dilatation. For detecting pulmonary vascular dilatation. Then what is the most specific confirmatory test? The most specific confirmatory test for your hepatopulmonary syndrome is, this is the new test, that is macro aggregated albumin lung perfusion scan. Okay, that is macro aggregated albumin lung perfusion scan. That is the most specific, and that will confirm the diagnosis of the hepatopulmonary syndrome. And not only that, even your HRCT also may be useful for detecting the dilated pulmonary vessels which are present at the base of the lung. And the treatment is that you need to give long-term oxygen therapy, and ultimately these patients, they will be requiring liver transplantation. Ultimately they will be requiring liver transplantation. Okay, so this is about your hepatopulmonary syndrome. Okay, right. So you can just get this PDF on DBMCI Premier Group on the Facebook, or you can just join my Telegram channel, that is Medicine Made Easy by Rajesh Gubba. So wherein you will get this particular PDF. With this, I'll wind up this particular session. So what all emergencies related to hepatobiliary system we have discussed, right? We have discussed all these emergencies: hepatic encephalopathy, portal hypertension, spontaneous bacterial peritonitis, 10 societies causing abdominal compartment syndrome, hepatorenal syndrome, and as well as the hepatopulmonary syndrome, right? So with this, I'll wind up the session. Then please let me know which all other emergency topics you want in the next session, right? You can comment in the chat box whichever the emergencies you want in the next session. Please text me in the chat box. Definitely I'll do that particular emergencies. Okay, so thank you very much. See you.